Good evening and welcome to Let's Get Physical. Tonight's webinar, or this morning's webinar, depending on where you are, on the role of exercise in cardiovascular health. And special thanks to all of you that have registered for this, some 1,500 or more, and particularly to our international registrants. I'll start, as we always do in Australia, by acknowledging the traditional owners and custodians of country throughout Australia and their connection to land, waters and community, and indeed around the world. We pay our respects to them and their cultures and elders past, present and future. We've got a wonderful panel today. We're going to start with Professor Martin Halle from Munich, who's a cardiologist and involved in preventive and rehabilitative sports medicine. Another cardiologist, my friend and colleague Andre Lagersh from St Vincent's Institute and the Victor Chang in Melbourne. And we're not all cardiologists. Nicole Freen is a clinical physiotherapist, an academic at the University of Canberra, and Professor Xiaoqi Feng, who's a professor of urban health and environment at the UNSW. And joining us as our GP overseer is Dr. Kulit Singh, who's also national chair of the RACGP Social Prescribing and Special Interest Group. Audience questions, we welcome them. We've got lots already, but we welcome more, and they can be submitted through the Q&A box. And I'd like to now hand over to our first speaker, Martin Halle, and he's going to give us a general overview of the role of physical activity in cardiorespiratory fitness as far as cardiovascular disease risk is concerned. Thank you very much, Martin. Marin.
Thank you very much for the introduction, and great to be here. Meaning here from Munich, Germany. You can see where I work. It's near the Olympic Stadium, and the university hospital is close. So physical activity is prescribed here on a daily basis. I went to the American Diabetes Association, and you can see how this looks like. So physical activity is not, well, they propose it, but they don't do it. And when people enter fitness clubs, they even take elevators or escalators. So physical inactivity is something we are facing around the world. Outlined here in a study looking at physical activity in men and women. Here, men, 30% are inactive worldwide. 17%, this is in the Southeast Asia region, and about 40% in the Americas and Eastern Mediterranean. Females, as outlined here on the next slide, are more inactive than men, and this inactivity increases with age and also income of the country. When it comes to children, this on the left is a children's play by Peter Bruegel, the elder, in the Middle Ages. Children were playing outside all the time. And nowadays, when it comes to what we're looking at here, are the Mediterranean, Asia, and Western Pacific, Americas, Africa, Europe over here, looking at different ages of physical inactivity. And then when it comes to boys and girls around 13 to 15 years old, they perform, 80% of them perform less than 60 minutes of moderate and vigorous activity. And you can see here that inactivity, as outlined, increases with age. Lifestyle is an important factor. Genes are important factors, and I would like to outline this. The gluttony here in Middle Ages, so Hieronymus Bosch outlined. They all knew what was bad. Maybe not they knew for the heart, but in general for health. The genetic risk, which I would like to focus here in combination with lifestyle, is increasing the coronary event rate of 10 years, which is outlined here. So we have the genetic risk over here, low, intermediate, and high. And these bars in blue and darker blue and red outline favorable lifestyle, intermediate lifestyle, and unfavorable lifestyle in red. So the combination of genetics plus lifestyle increases the 10-year coronary event rate. So there's atherosclerosis and myocardial infarction and so forth. So, but what is important here is if you do have a high genetic risk, and this is over here, and you have a favorable lifestyle, this is far lower, then you do have a low genetic risk or intermediate risk, and an unfavorable lifestyle. So lifestyle beats genes, and this is very important. They are still there, the genes, but lifestyle seems to be really having a tremendous impact. And physical fitness, in this sense, does have this particularly. And this is from the same analysis and study. We do again have the genetic risk. And here we have low fitness, moderate and high fitness. And what you can see here is that with a high genetic risk and high fitness, the risk overall is significantly reduced and halved, as you can see here from the red to the green bars. So the consequence of physical inactivity and sedentarism is dementia, it's brain insulin resistance, it's coronary heart disease, elevated blood pressure, it's diabetes and hepatic liver disease and sarcopenia, so muscle loss and low exercise capacity and impaired vascular function. So lying on the couch is certainly not what genes and humans and animals overall are prone to do. That physical activity does have a significant impact and is reducing cardiovascular risk comes from a study in the 50s from Jeremy Morris. He was an occupational medicine doctor, and he did studies in these bus drivers. And these bus drivers were the ones who drove the bus and comparing these to the conductors. So the conductors did physical activity, drivers did not, only rotating the steering wheel. But when you look at the comparison between drivers and conductors, you can see that the conductors significantly had lower incidence of coronary heart disease. And this was also shown for telephonists and postmen. And current data really do also reveal the same issue as Jeremy Morris already found. So there's physical activity here. It is outlined here in MET minutes per week. MET is intensity. When you sit is 1, when you walk is 4, when you jog is 8 and above. So MET per minutes per week is physical activity. So what is most importantly outlined here is cardiovascular disease in red and no cardiovascular disease in blue. It works for both. And what's important here, it also works for the 10-year risk of cardiovascular disease at any risk, 5 to 10, lower 10, and more than 10%. And what's most important here is that, yes, here is the main reduction of mortality. And the reduction of mortality and also cardiovascular risk is from 0 to 500 MET minutes per week. And this is 15 minutes of walking or brisk walking per day. So it is not the 30 minutes, actually, it's the 15 minutes that really does have the most effect. And running a marathon is not doing any better. So the recommendations of physical activity here from all associations, Europe, America, Australia, and so forth, recommend 150 minutes of moderate intensity, and this can be halved to 75 minutes if activity is performed at higher intensity, vigorous activity on most days of the week. So intensity, the higher the better, is obviously something that is an issue. And I would like to outline this because it strains the periphery, and this is a muscle with all the metabolism here. It strains the muscle and improves metabolism. Data here from Copenhagen City Heart Study, looking at about 20,000 male and females since the 70s, found that for men and women, men in blue, and female here in this is it race color. The intensity, low, moderate to high intensity, shows that the high intensity, when it comes to life expectancy in years, has the most effect, and this holds true for females and males. And it's not the duration, it's more the intensity, because the duration here did not increase life expectancy. Also, other data here from the UK Biobank, investigating over 80,000 individuals, mean age of 62, and body mass index as outlined here, looking at accelerometer data. So they had over 6.8 years, they had 4,000 events, and this was coronary heart disease and stroke. And the physical activity outlined here in volume and intensity over here clearly shows the volume is important, but the intensity is also something that really reduces cardiovascular event rate. And a 14% reduction is seen when changing from 14 minutes of moderate intensity to 7 minutes of brisk walking. So intensity is clear. And the next question is it okay if I just do it on weekends rather than during every day of the week? And very recent data here showing the weekend warriors and 5-year cardiovascular risk, and particularly regarding cardiovascular risk factors I would like to outline here is when it comes to 5-year observation of the cumulative risk of hypertension, the weekend warriors and the regular walkers and exercise individuals, they had the same risk. And the inactive individuals had higher hypertension, higher incidence of diabetes, more sleep apnea syndrome, and also more obesity. And the other lines of weekend warriors and regular physical activity individuals were in the same line, actually. So another question then is that I'm always asked by my patients, will I do physical work? And what about, do I still have to go to a gym? And this is something that is called the work paradox. And the work paradox outlines that physical activity, when performed during leisure time, really, as we outlined already, reduces the risk from 20 to 30% regarding here cardiovascular risk and acute myocardial infarction. And these are all the positive effects of sufficient recovery, optimal metabolic intensity, duration obviously seems fine and improves autonomic control and other factors. When it comes to occupational time that's spent with physical activity, this is not the case anymore as outlined here, and this is explained by factors like psychological stress at work, impaired autonomic control, environmental strain, prolonged elevated blood pressure because exercise is performed 8 hours rather than only 15 to 30 minutes, and the repetitive bouts of resistance exercise over the whole week is also something that is seen as an underlying factor. But clearly, this has not been resolved overall. When it comes to the cardiovascular risk score, and this is from the ESC risk score 2, data of risk factors, age, sex, smoking, blood pressure, and cholesterol are entered here. And these risk factors, as outlined here, they should actually be related also to physical fitness, because physical fitness, when it comes to the risks for cardiovascular disease, death, so that's mortality, is on the other side of the risk factors, certainly in men and women. But when it comes to smoking, when it comes to diabetes and age, this is something that you really appreciate, wouldn't you? Is that physical fitness And in this direct relationship, the better the fitness, the more the effects of reducing cardiovascular disease death is protecting even when you do have cardiovascular risk factors, the classical cardiovascular risk factors. And I would like to highlight just very briefly hypertension here. Again, from the Copenhagen City Heart Study, they did echocardiography, so ultrasound of the heart, looking then also at activity, inactivity, light activity, moderate activity, and this is follow-up here over 20 years as outlined before. On the left is the left ventricular hypertrophy, and you can see here that hypertension together with left ventricular hypertrophy has a significantly increased cardiovascular event rate when you compare this here to non-ventricular hypertrophy. And here, moderate activity and also light activity in both patient groups does significantly reduce the risk. And the other example I chose was optimal exercise training in metabolic syndrome and type 2 diabetes. And physical fitness here, and this is an early study, but I still like it very much, by Stephen Blair and his group, looking at over 8,000 individuals in the Cooper Clinic in Dallas. And when it comes to obesity, that's over here, and the development of type 2 diabetes, yes, this is significantly higher than in those with a body mass index below 27. But when it comes to elevated, so overweight and obesity, and comparing low fitness versus high fitness, the high fit individual with obesity, overweight and obesity, they have a lower risk than those who are non-obese but physically inactive or have a low physical fitness. So physical fitness really counteracts obesity. And when it then comes to intervention of exercise in diabetes, this is over 9 months intervention, and comparing control versus resistance training, endurance training, and combining the both, it is clear that resistance training in changing HbA1c in diabetes has the same effect as endurance training, and the combination, particularly when it comes to longer observation, is the best. So if we look at muscle, if we look at the metabolism of the liver, vascular function and myocardial adaptation by exercise, of high intensity, moderate intensity, or even resistance exercise, there are different effects as outlined here. More here, less here, more here. Like for metabolism of the liver, the high intensity endurance has more influence than resistance exercise. And this is outlined here when it comes to uptake of maximal oxygen consumption, mitochondrial function, body weight, exercise capacity, then insulin sensitivity, lipid metabolism, or even myocardial function. And the largest study in type 2 diabetes is the Look Ahead trial. And this Look Ahead trial looked whether exercise, when introduced in this high-risk group, did have an effect when it was aimed at reducing weight by 7% or intensifying physical activity in this group. And after 10 years, they all were really devastated, because after 10 years in the Look Ahead trial, the clinical endpoint did not change. Clinical endpoint of coronary artery disease, acute myocardial infarction, stroke, and hospitalization. So, when looking at then the physical fitness data, it clearly came here after 4 years that that physical activity declined. So adherence to physical activity is the most important thing. So the right choice is taking or buying the right dog, jogging the dog, buying a big one or one that tears you. And this is not enough when you just buy a dog and don't use the treadmill yourself. Yes, it is physical activity. It's not the apples only that keeps the doctor away. But in the sense, if they have a job, then it's even better. So thank you very much for your attention, and I'm open for any questions.
Thank you very much, Martin. That was a great start to this webinar, and I think you've got us sold on the issue of exercise or physical activity being good for you. But is it good for everyone, and particularly with people with various forms of cardiovascular disease? And we've got the perennial question of many athletes have big hearts, and yet we think that if someone with hypertension or heart failure gets a big heart, that's a very bad thing. So how do we decide whether somebody's got athlete's heart or a cardiomyopathy or some other condition? And that's where one of the things that Andre Lagersh, or some of the things that Andre Lagersh is going to cover in his next presentation, defining exercise-induced cardiac remodeling. Thanks, Andre.
Thanks, Gary. Let me just get this fired up. So thank you. Perfect introduction, Martin, and thanks, Gary. Indeed, I'll be talking about, to some extent, the extreme end of the spectrum with athleticism, because sometimes we forget that exercise is one of the most powerful, has one of the most powerful effects on the heart muscle. I'll detail that at some length, but it also has an effect on the electrics and also the arteries of the artery. And I'm going to cover those three main areas of cardiology, starting with heart structure and function. In athletes, exercise profoundly affects heart size. So much more than blood pressure, even more than most sort of heart valve problems. This is an example here of a 23-year-old librarian versus a 23-year-old marathon runner. And the chest wall and all of the structure, the spine, they're all the same size, but as you can see, the heart is literally twice as big. And there's a very strong relationship between fitness, which is shown as these little dots on the graph, and on the y-axis, and heart size, volumes, mass, however we want to measure it. And these are two actual dots from the graph of a relatively sedentary person and then a triathlete, and their hearts to scale, showing again that the heart of the athlete who is twice as fit will be twice as large. If we've looked at hundreds of young elite athletes and can demonstrate just how massive these hearts are. So these are indexed values. Don't worry too much about the dots and the values, but just to make the point that some of these hearts at over 200 mil per meter squared, volumes in the sort of high 300s, 400 mils, when a normal heart is in the 100 to 150 mil for a ventricle. So we're literally talking 2 to 3 times the size. What happens when the heart's that big? Well, they're big, they're slow, and often the function by normal metrics can look quite low. And if we look at elite athletes, it's not uncommon for us to be able to measure reduced ejection fraction. Not severely reduced, but more in the range of 45 to 50%. And we see this not uncommonly. In this case, 16% of these elite athletes who are sort of Tour de France cyclists or international rower type athletes. And the question then comes up, is it healthy to have such a big heart? Is it a problem to have this sort of measures of reduced function? Because if you see these in your clinic and it comes back saying mild systolic dysfunction, you wonder what's going on. And it introduces one of the really key things with studying people, studying athletes, which is don't just look at the heart at rest. We do a lot of work looking at the heart during exercise with echocardiograms, and we've perfected this technique of exercising people within the MRI bore and having a look at the heart going flat out and measuring the volumes. And we can, using this technique, we can identify the healthy heart versus the mildly sick heart. Again, some sort of complex graphs, but essentially at the top is some data of ours where we compared healthy athletes with this low ejection fraction versus people with cardiomyopathy with a low ejection fraction. And in the athletes, every their function improved, their ejection fraction improved with exercise in every case. Whereas in the dilated cardiomyopathy, in many cases, the function didn't improve or got worse. They're the graphs at the top. At the bottom, it's always nice when someone validates your work, and 2 years later, using almost exactly the same graphs, a group from London showed exactly the same thing. So I think we can regard that as truth. So there's a lot more I could talk about with the big heart, but essentially in a nutshell, the big heart is more compliant, associated with more fitness, and has the lowest heart failure risk. Just want to take a moment and also better survival. This is just, Martin detailed this at some length, but just a somewhat humorous example of the first 200 people who ran under the 4-minute mile, who on average lived 5 years longer than age-matched people from their country. So even at the highest levels of fitness, there's a longevity benefit from being uber fit. What about at the other end of the spectrum? And I think this is really important. Given that fitness and heart size go together, what does it mean when you've got a small heart? Ben Levine and some of their colleagues in Texas have shown quite nicely that if you don't use it, you lose it. If you go to bed for 12 weeks and don't get out of bed, then you lose about 30% of your fitness and lose 30% of your heart mass. And it takes years for that to recover again. It is absolutely critical, particularly in today's day and age where people are sedentary more and more of the time, to recognise the impact that has on the heart. We looked at this in women, with particular interest in women because of the fact that they're more, on average, more susceptible to developing heart failure with normal ejection fraction. And we could demonstrate that those people, firstly, this, again, very strong relationship between heart size and fitness, which meant that if you had a small heart, you were more likely to be less fit. And what we could do with the exercise MRI is demonstrate that there was a double whammy. If you had a small heart, you had less volume to move, but you also, that stroke volume, the amount of blood that you pumped with each beat, normally during exercise that increases, but the smaller the heart, the less increase there is. So you have less to start with and less improvement to make. And the result of that, again, is that you can have, that has an impact both on heart failure, but also on survival. This is one of our PhD students and cardiologist, Stephanie Rowe, who studied nearly 400,000 Australians and divided up into quartiles of heart size. And the smallest quartile had died earlier than people in the other quartiles of heart size. So a small heart is bad. What can we do about it? Exercise. So Steve Folkes, one of our best researchers and supported by the Heart Foundation money at times, has demonstrated in a slightly different population, in women with breast cancer who were undergoing chemotherapy, an additional reason to lose fitness and heart size, and could demonstrate that if people had a supervised exercise program, their fitness improved, their heart function improved, and their heart size improved, relative to people who just underwent usual care. So there is an answer to this both ways. If you don't exercise, your heart will get smaller and you're at higher risk of heart failure. If you do exercise, your heart will be bigger and you're at lower risk of heart failure. What about electrics and coronary disease? I'm going to move on to electrics. And here there's a little bit of a sting in the tail, in that those people doing very high amounts of exercise have been shown by multiple groups to be at slight risk, higher risk of atrial fibrillation. We looked at this in Olympic level rowers at really almost middle-aged, an average of 61 years, and demonstrated that rowers had a prevalence of atrial fibrillation of 21%, i.e. 1 in 5 rowers had atrial fibrillation versus 3% in the general population. So a 7-fold risk in former elite rowers. This is largely because of their high levels of exercise, but there's also a genetic component. This is Dai Fatkin from Victor Chang, who we worked with using a technique called polygenic risk scores, so looking at multiple different genetic traits, and could demonstrate that in athletes and in non-athletes, I might have just gone dark, there was a genetic risk as well as the exercise risk. So it's also a little bit about family factors. What about coronary artery disease? Now, somewhat disappointingly, there's quite some evidence that doing more exercise seems to increase coronary artery disease. A big caveat here is that it seems to reduce your risk of heart attack, yet increase the risk of having some gunk in the arteries. This was demonstrated by a Belgian group that I work with who compared people who had been athletes for their whole life versus athletes who had become athletes more recently. And in every measure, coronary calcium, number of plaques, where the plaques were, how many people had more than 50% stenosis, in every case, the people who were at highest risk were lifelong athletes. So you would wonder whether, therefore, athletes are going to have more heart attacks, when in fact it's quite the opposite. This is one of my favourite graphs from our colleagues in Texas, Ben Levine. This is people who had a coronary artery calcium score, and looking at their clinical event rates 5, 15 and 25 years later. And for example, if you have a coronary calcium score over 400, then at 25 years, your risk of a heart attack or stroke is around about 50% if you're unfit. But along the x-axis is your fitness. And if you're very fit, that reduces to 20%. That's a 60% relative risk reduction. And if we compare that to things like statins that are around 20, 25%, this would suggest that exercise is our most powerful way of reducing heart attacks. So let me conclude. Exercise means living better for longer. Exercise results in a bigger heart, better exercise capacity, lower risk of heart failure, and a lower risk of premature death. There are some side effects to really intense exercise training, particularly risk of some arrhythmias like atrial fibrillation. There may be more coronary disease, but importantly, fewer heart attacks. And I think the thing most about exercise we forget, we think about, am I going to have a heart attack? How long am I going to live? The most important thing with exercise is life's just better. And I think that's best summarised by Amby Burfoot, who won the Boston Marathon, who said, I run to add life to my years, not to add years to my life. Thank you.
Thank you very much, Andre. That was terrific. We're going to, I think we got the idea now that if we could get everybody exercising, they'd be better off. But how do we, I think the next part of this discussion is going to be how we do that and in whom. And I'm going to hand over now to Professor Nicole Freen, who's a physiotherapist, and she's at the University of Canberra, and she's going to talk about some of the relationships to cardiac rehabilitation and physical activity.
Fantastic. Thanks, Gary. I'm very excited by the two presentations before me. Thank you very much, Martin and Andre. It's perfect for me as a physical activity nut, physiotherapist and researcher. So tonight I'm going to actually present the CSAT's position statement on assessment and prescription of exercise and physical activity in the cardiac rehab setting. This has been endorsed by the APA, SR and ACRA. And before I go any further, I'd just like to acknowledge our international multidisciplinary writing group that pulled together this position statement in 2023. So most of you will know that over 4 million Australians are affected by CVD. CVD causes 1 in 4 deaths in Australia, and coronary heart disease is the leading cause of death. But many more Australians are living with CVD due to improved diagnosis, treatment and management over the longer term. So international guidelines recommend that people with CVD should be referred to secondary prevention programs such as cardiac rehab. And exercise-based cardiac rehab has really strong evidence to support its use. It decreases hospitalizations and AMI rates. It improves CVD risk profiles, exercise capacity and quality of life, particularly in patients with coronary disease. But we also know that exercise programs are beneficial for patients with other cardiovascular conditions, as we've listed here. So in 2014 in Australia, ACRA released some core components of cardiac rehab, but within these core components, there was very little detail about the assessment and prescription of exercise and physical activity. More recently, internationally, there have been more detailed guides about exercise and physical activity. And there's also been increasing evidence about the use of mHealth and telehealth in assessing and prescribing physical activity and exercise. So we thought it was about time in Australia and New Zealand that we put together a document to provide us more information or more guidance. And we also really wanted to highlight the importance of a patient-centred approach. So our overall objective of this position statement was to provide a really pragmatic evidence-based guide for the assessment and prescription of exercise and physical activity by all clinicians working in cardiac rehab, particularly in that Australian and New Zealand context. We wanted to do that by summarising the assessment and prescription of aerobic exercise, resistance exercise and physical activity for all the patients that are referred to secondary prevention programs. So I'll start with aerobic exercise. You'll notice there's QR codes on each of the slides. All the references, all the detail, if you scan that, it goes to our position statement. So there are various ways that we can assess aerobic exercise capacity. The gold standard is cardiopulmonary exercise testing, so with gas analysis, and then you can move further down the line. And what we commonly see within our cardiac rehab programs in Australia is the 6-minute walk test, which is a submaximal test and it assesses functional exercise capacity. Now, in order to do that assessment, you must do a comprehensive assessment of the patient, taking into consideration any contraindications. You should do that assessment, and then it should inform your prescription. And we've used the FIT VP principle to provide some recommendations for the prescription of aerobic exercise. So FIT VP stands for frequency, intensity, time or duration, type of exercise, volume and progression. So for aerobic exercise, the recommendation is to do aerobic exercise 3 or more days per week at a moderate to high intensity. You're aiming for sessions of 30 minutes or more. We recommend a variety of aerobic modes of exercise. And what you're aiming for is a minimum of 150 minutes of moderate to high intensity aerobic exercise. Patients should start slowly, progress gradually, but we mustn't forget that we do need to progress them as their cardiorespiratory fitness increases, so they keep getting the benefits. Now, in Australia, we tend to be a little bit more conservative with the prescription of exercise within cardiac rehab programs compared to the rest of the world. And part of the reason is we tend to do those less technical assessments of aerobic capacity, such as the 6-minute walk test. But there is increasing evidence for the use of high-intensity interval training in cardiac rehab settings with certain cardiac populations. And it is used more frequently internationally. So it has been found to be safe and beneficial for some groups, and it can even provide benefits above that of moderate intensity continuous training. But again, it's really important to see whether the patient's suitable for this and whether the patient ever wants to do high intensity interval training. When we're looking at resistance training, we should do a comprehensive assessment, which includes an assessment of muscle strength. There are various methods there. Again, in the paper, we go through the pros and cons. 1 repetition max assessments is what we recommend. But of course, you can do those low resource assessments. So for example, there you could time how long it takes your patient to do 5 sit-to-stands. Again, we've used the FIT VP principle. So we recommend doing resistance training 2 to 3 times per week at a moderate to high intensity for 20 minutes or more each session. The type of resistance training, it can be whole body, single or multi-joint exercise, do bilaterally where possible. And the total session volume per major muscle group is 15 to 36 reps. Again, patients should be encouraged to start slowly, progress gradually, and continue to progress once their strength increases. Now, physical activity, which is something that I'm very passionate about, and this is something that all of us can actually assess. We don't need to be an exercise specialist, which is more necessary for the previous two areas. So any of us, whether we're a GP, a nurse, a dietitian, a physio, an EP, it doesn't matter. We can all assess physical activity, and you can do that using a device such as a pedometer, accelerometer, or inclinometer. But you can also do it via self-report, so using physical activity questionnaires or activity diaries. So again, looking at the FIT VP principle, you should be encouraging your patients to do moderate to vigorous physical activity on most days per week. The aim is to do 150 to 300 minutes of moderate intensity, or 75 to 150 minutes of vigorous intensity, or a combination of both per week. In addition to that, we should be encouraging our patients to break up long periods of sedentary time. So again, we recommend a variety of moderate to vigorous physical activity. The aim is 150 minutes or more per week, but you can also look at steps, which patients quite often like. So we recommend trying to achieve 7,500 steps per day or more. Again, starting slowly, progressing gradually, and working towards those aims. But the key message here is anything is better than nothing. And from Martin's slides earlier on, you can see that sedentary individuals have the most to gain. So as I said earlier, there's been increasing evidence for the use of wearable activity trackers in cardiac rehab settings with cardiac populations. It has been shown to improve physical activity and aerobic capacity, but we do need to review the devices. For example, we need to make sure that they're measuring what we want them to measure, is it accurate, and whether or not patients actually want to use it. So if they do want to use an activity tracker or they have one, take advantage of those opportunities, encourage them, educate them, monitor them, provide that feedback loop to promote that continuing engagement and autonomy over the longer term. In terms of telehealth, it's not a barrier to exercise and physical activity assessment and prescription. You can do this effectively, but you need to pick the right patients to do this in the right environment. So within our position statement, we've provided a figure which summarises everything that I've just gone through. And we've finished up with a summary and providing 5 recommendations. So it's really important that a comprehensive individual assessment of each of those 3 areas is done to determine any limiting factors, to allow safe prescription, and also to individualise the advice or the prescription of exercise or physical activity to our patients. If we are measuring or assessing aerobic exercise capacity, muscle strength, or physical activity, we should always do it again at the end of a program or the end of a period of time when we've seen a patient. This will guide target intensities, but it'll also show whether the program's been effective. For cardiac rehab, of course, we're encouraging a range of exercise and physical activity options, but the key here is that moderate intensity physical activity or exercise. This is where you get your best bang for your buck. So we really want people to try and aim for that moderate intensity, which is different for everyone. As I talked about earlier, moderate intensity continuous training, we know that it's well established, it's safe and effective for cardiac patients, but there is increasing evidence for the value of high intensity interval training for selected cardiac patients that can possibly result in increased improvements exceeding that of moderate intensity continuous training. And again, if patients have wearable activity trackers, if the only way you can interact with your patient and talk about physical activity and exercise is via telehealth, there is evidence to show that these things do improve exercise and physical activity. They improve quality of life. They support and empower patients to self-monitor, and they increase their confidence to be active over the longer term. Thanks, Garry.
Thank you very much. That was very clear, and I'd certainly commend that CSANZ position paper to people that they can download from the QI code. We're going to move on now to some of the systematic or system barriers really to physical activity, because all very well saying it's good for you, but how do we create an environment that is where it's accessible where can we, how can we make sure that we help people on the road to physical fitness. And we're very fortunate to have Professor Xiaokui Feng, who's Professor of Urban Health and Environment at UNSW, who's going to guide us a little bit on that path. Thank you very much, Xiaokui.
Thank you very much, Gary, for the introduction, and also thanks Heart Foundation inviting me to give a talk, and I'm looking forward to the discussion. I'm now going to share my screen, see how it works. Okay. Okay, can you see my screen?
Yep.
Perfect. Excellent. I really enjoyed about the presentations from the previous speakers and learn how important the physical activities to our health. And I've now started thinking I need to have more physical activities today. I haven't achieved today's goal yet. But as Gary said, you know, even people know physical activity is really good for our health, but how we can bring people and motivate them and get them actually do more physical activities. So one way is potentially social prescribing. We have this question in our mind, whether social prescribing promotes physical activity, quality of life, and also the cardiovascular outcomes good for our heart. Just a quick question, ask our audience if you have ever heard about social prescribing. I know you may not put your hands up, but if you have not heard from it about the social prescribing, you might want to have a look. So I have a similar question, and I'm thinking, well, does that work? Does that actually help promote physical activity? And as a researcher, and also many of you as a doctor, you probably would agree with me that RCT, the randomized trials, probably will tell us the answer. So with that in my mind, my team and I start a systematic review. And we have this question, how effective are the social prescribing interventions for the management of any disease conditions in adults? This is more about chronic diseases. But we also want to learn that what are the costs associated with social prescribing interventions? Because if social prescribing is so good, promote physical activities, good for our health, social connections, and then we want to make sure it's cost effective and efficient. So we went through many of the databases to conduct our research, as you can see on the screen. But if we have missed any of them, please let us know. We focus the participants in those research for adults aged 18 and over who have been diagnosed for any non-community diseases. This also including mental health issues as well. And the intervention, this is where we're looking about social prescribing intervention delivered by non-healthcare professional or social prescriber or a link worker in community settings. And we look at quite a lot of outcomes. This is previous systematic review did not look at. We look at quality of life, depression, loneliness, healthcare utilization, and also some objective measurements such as HbA1c and or cholesterol, BMI, and also cost. And of course, physical activities is one of the outcomes we're looking as well. So this is where we are getting so far. After a massive screening, and then we are so far have 42 studies included in our research, and we are still continue to do the screening when I am speaking. But this chart I find is really interesting because we find 42 trials on social prescribing, which is RCTs. And as I said, there are still 44 under review. But as you can say, wow, this is really a booming and fast developing research area. It come to 2023, it suddenly have like 12 RCTs. And then in 2024, we haven't finished and we have 10. And in a recent social prescribing international conference, I just come back from, I know that there's a more actually is running and probably will publish next year. And there are major outcomes that we're looking: blood pressure, obesity, healthcare use, anxiety. So far, this is all the outcomes we have found from the 42 studies. We haven't seen any of the physical activities RCTs done with social prescribing. It might be in that 44 studies, which we haven't screening yet. So we hope that we'll able to report soon. Although we don't have a sure answer yet whether social prescribing promote physical activities and other health benefits, but we know some type of social prescribing seems works really well, which is nature prescribing. So I'm going to talk a little bit about nature and health. I have done a lot of work on nature and health. So I'm just quickly go through with you some of the key research outcomes that we have found goes through the life course, how nature benefits our health. So go from when we were a baby. So our research find that if moms living with 30% or more green space when during the pregnancy, the baby tend to have lower risk of developing low birth weight. And we know this is really important because low birth weight associated with higher risk of heart diseases risk later. And we also find that more green space is also means kids have a lower risk of lipid level. And again, this is really important to our future health, especially about heart diseases. And we also find kids who living with higher traffic area, they tend to have more risk of developing asthma. But if they happen to living with 40% or more tree canopies in their neighborhood, this risk of developing asthma significantly reduced. And also it's good for our children's mental health well-being. Especially for the children and others as probably as the introvert, more green space seems really good for their mental health well-being. And when we grow up a bit, well, we tend to find it a little bit more lonely. But what we find is that people living with more green space, they tend to feel less lonely. I'm not surprised because you tend to go out more and see your neighbors and walk around and do physical activities. And this is a really interesting study. My research found that moms living with high quality green space, the risk of developing postpartum depression is reduced 26% of odds. This is after we controlled for those important risk factors such as education and income. So high quality green space is really important for our moms. And if we can do that, that could reduce the risk of psychological distress, depression for our moms. I think that's a really great news. And of course, green space is for all of us mental health well-being, and also help reduce the risk of developing high blood pressure, diabetes, and also heart diseases, and even reduce the emergency department visit for major cardiovascular diseases event. So when we get older even, and we find that people living with more tree canopies, we talk about 30% or more tree canopies in our neighborhood, is a reduced risk of developing dementia. And not only help us live longer, but also healthier. So without this, it's great. But our research, where a recent National Australia study, we find, unfortunately, 42% of people with diabetes spend less than 2 hours a week in nature. So all that benefits I'm talking about, they're not going to get it because they are not being nature. But the good news is 71% of them said they're interested in nature prescription from a health professional. So you may say, well, who need a nature prescription? You may say, oh, I often go into nature, going to green space. I don't need a nature prescription. I agree with you. If you are doing that, it's fantastic. Keep going, carrying on. But we had people that they could benefit from the nature prescription. For example, people have very poor access to the nature and meanwhile have very low motivation being nature. or people actually have quite good access to the nature, but they just lack of motivation rather than stay inside of home to watching Netflix. This could be one of your patients. And if you have them, it might be worth to considering issuing a nature prescription or refer them to a link worker. And you may also say, okay, Xiao, you said all this great thing of nature, I agree, is fantastic. Where's the evidence and whether nature prescription work? We conducted this systematic review published at Lancet Planetary Health, and we find that nature prescription works. It helped reduce blood pressure and also reduce depression and anxiety. And it's also helped promote physical activities. But there's clearly not enough RCTs done, especially in a reasonable large size as well. And luckily, we received the funding from MRFF, and we are currently conducting this. Probably is one of the largest RCT on nature prescription in Australia. It's called a PANDA study, which is very opposite from PANDA because the whole trial is to promote more physical activities in nature for people who age 45 and 45 age and older, and also with cardiovascular diseases. So we just finished our first phase, the co-design, and we are going to start our recruitment. If you or your patients or your family, friends, they haven't spent 2 hours in nature and not quite physical active, please just mention and or promote our study, PANDA study, to them to join the trial. Thank you. And I just want to give a shout to Heart Foundation's walking program. And if you're interested to do more walking in nature, and you can not only just do by yourself and with your family, friends, you can also find a group and meet more new friends as well. Thank you very much. Looking forward to our discussion.
Thank you very much, Xiao Kui. I'm looking forward to our discussion too, because there's lots of issues there and a lot of them are coming through in the Q&A. But let's talk about how it works in the hurly-burly of clinical practice, particularly in general practice. Is it really, as Martin says, a matter of getting a dog, and then Xiao Kui says take it to the park or the forest? How do you make it work? What works in general practice? And we're fortunate enough to have Dr. Kuljit Singh to talk about that, and I'd be interested in your advice to GPs in how you identify and manage patients with low physical activity levels. Yeah. Thank you very much, Kuljit.
Thanks so much, Gary. Thanks for having me here tonight. And I loved everyone's presentations. I think firstly, it's really important, like you said, to identify the patient that's having low physical activity. And that could start right at the outset when a new patient is enrolling into our practice, getting all their demographic details and maybe checking in on what their physical activity level might be. But then taking a look at opportunistic, consultation times where we might be discussing or reviewing their lipids or checking their blood pressure, or checking their sugar. And we might say, well, by the way, also, let's talk about your exercise or activity level too. So I think it's really important to spend that amount of time, not just brush over it. Because it is so significant. Like everyone's been saying, it is just as important, if not more important, at times than our medications. So I think it is really important to focus and really spend a bit more time on this lifestyle intervention, which is so powerful. And I think in terms of managing patients, often it is a matter of, motivating the patient, finding their why, like why is it important to them? What is their reasoning? Being able to present, I guess, statistics or giving them an idea of their cardiovascular risk. So really individualizing all of that for the patient and making it important to them.
Thank you. So you would have a lot of patients with multiple risk factors and comorbidities. And where does physical activity come in when the patient comes with a list of 3 or 4 conditions and 10 drugs?
Yeah, well, look, absolutely. I mean, physical inactivity is one of the biggest risk factors for so many conditions, not just cardiovascular disease, it's for cancer, it's for diabetes, it's for, even for depression, our mental health issues as well. So I think, again, there is such a multitude of benefits from really promoting physical activity, not just for one reason, but for so many. And I think that's what everyone is wanting, right? We want a happy, longer, good quality life, and that's what we're all about. We're into that whole preventative approach as well, rather than, you know, curing at the end. We would love to really focus on those lifestyle factors. So I think that's pretty much, you know, the emphasis is even more important if they've got multiple conditions. To really, I guess, from our point of view, we need to impart that importance and that significance of how much of a positive benefit they really can have on their physical and mental health by simply implementing. And it is very simple, but for a lot of us, we are time poor. You know, we've got so much other stuff going on in our lives, but it's just a matter of starting slowly and building up gradually, I guess. But as I said, if we're working as a team, as a collaborative effort, and if we are motivating them and they feel the, I guess, the importance of it coming from us and our team, I think they're more likely to succeed and attempt what we're suggesting.
Okay, so we know that telling people to just get some exercise and lose some weight doesn't work. We've got to get more specific than that. We've got to find out what sort of exercise might be suitable to them, what they're likely to continue doing the rest of their life, what are their opportunities for improving their nutrition. Where does allied health come in supporting you in general practice in that?
Look, I think firstly, it's probably, again, important to ask, you know, what does the patient enjoy doing? I think, again, coming back to that whole individualized approach, you know, if we say to someone, you know, go for a swim, but they don't like water, they like walking, for instance. So we really need to listen to what our patients really like to do, and individualize that approach first. So what's important to them? What are their passions? Because it's more likely they're going to sustain that activity for longer if they actually enjoy it and possibly have a variety of activities. And like Prof Feng was saying, maybe doing activities out in nature and with a group is probably more motivating and more likely to be sustainable and fun. Allied health is very, I guess, important too, because again, we've got the whole team approach happening. So we're able to further reinforce what we're saying, but also to motivate, to continue to empower, to teach things correctly as well, and to keep checking in with our patients, because often as GPs, we might not have that much time, but if we're able to say, okay, would you like to come to our nurse, or would you like to come to the physio or the EP? And we're going to continue the discussion and have some regular follow-up as well. So again, I think they feel like, you know, there's a whole team approach happening here. We are important, you know, and we're all working together collaboratively. So it just makes them feel better as well, that we're really taking an interest in them.
Yeah, so that could involve nutritionists, sports scientists, and there's on the chat line from Fiona Batchelor a mention of health psychologists who are trained in behavioural change and
absolutely.
Deal. But really, as you say, it's a team effort.
Yes.
Let's open up the questions now to the whole panel. And I'm going to go back to our first two presentations because Martin, in your presentation, you talked about physical activity at times, and other times you talked about physical fitness, and they're not the same thing. And I noticed, Andre, you tended to stick with physical fitness, and a lot of the activities that Martin presented epidemiological benefit from actually wouldn't do too much to VO2 max or some other hard measure of physical fitness. So what's important, and where do you think we should be focusing our efforts? Can we have all the speakers on screen, please? Cool, just feeling lonely.
I might just, can you see me or hear me as well?
Yeah, we can see you.
Yeah, all
we
right.
Can see you.
Gary, thank you for the question. This is an important one. And this is why I also outlined the genes and the physical activity and the comparison between the one and the other. I think fitness is determined by the genetic profile of the individual more than certainly physical activity. But I do also see there is also a link from genes to then actually for those who do then persuade themselves to do some physical activity. So there may also be some genetic impact there. But clearly, physical fitness is an important nominator because it combines the genes and physical activity. So if you want to find a prediction score and add then in comparison to the cardiovascular risk factors, then fitness, I think this is a good choice. Physical activity in patients certainly does also improve physical fitness, but it has to be said that that the impact is not as great as we or most people think. So I think it is very limited. It works in athletes, certainly, in those who do regular exercise at a certain intensity. So, I mean, like 3 times per week, and then increasing their intensity over time. And then you can see really improvements of 20, even 30 or more % of physical fitness. But for the general recommendations I also outlined regarding what is really protecting the heart or the cardiovascular system, it is the 15 minutes of some vigorous activity, moderate to vigorous activity every day. This is not the training concept for improving physical fitness to a major extent that then leads to reducing the cardiovascular risk overall if you take the measurement or the parameter like, maximal exercise capacity.
Okay, thank you. Andre?
Yeah, I agree with Martin and also Nicole, who both put an emphasis on different types of exercise. I often tell patients to keep it simple. I say, should treat exercise like a diet. And you know how people say you want a lot of colours on your plate? I tell people that they want a little bit of low intensity, if you like, activity for metabolism. They want a bit of high intensity exercise for the fitness, and they want some strength training for the muscles. And even though I've separated it out into those 3 things, actually the real beauty is that they're all synergistic. You know, if you do a bit of each of those, you get the 3 of them added and more. So, for example, if you don't do strength training and you're 70 years of age and you go for a jog, you get an injury. So everything ties into each. So I tell patients they want a bit of everything on their plate.
Gary, can I jump in here?
I'd like you to jump in.
So, I think it's a really important question to, work out what the difference is between physical activity, exercise, and physical fitness. So, physical activity is an umbrella term, and exercise is a subset of physical activity. It's repetitive, it's structured, and it's planned. And not everyone likes exercise. In fact, some people hate exercise. Physical fitness is the main goal of exercise. And of course, that we're talking mostly about cardiorespiratory fitness. And we know that that's a really strong predictor of mortality. But physical activity at moderate to vigorous intensity is also a really good predictor of mortality. And the physical activity guidelines internationally recommend that we do 150 minutes or more of moderate to vigorous physical activity. Now, that includes exercise. It doesn't talk about fitness, and fitness is separate from that. And if you do enough physical activity at moderate to vigorous intensity, you will increase your cardiorespiratory fitness. So those terms are a little bit confusing. And I think it's important that people realize you don't have to exercise if you don't enjoy it. And I think particularly, GPs are really powerful. And if we keep banging on about exercise all the time, it might actually, there'll be some people that just have never exercised and they never will. There'll be some people that haven't exercised for a while. So we just need to understand that any movement is better than none, but that intensity is really important.
I think that's a very important point, the fact that any exercise is better than none. We don't want people feeling they've failed and given up because we've set them unreal expectations. And I'm sure that's something you see in general practice. Let's go to the other extreme, and it's probably for Martin, Andre, and or Nicole. Can you overtrain? And there's some of those consequences you talked about, like atrial fibrillation, etc., a reflection of people doing too much and entering the area of diminishing returns as far as their heart risk is concerned?
Maybe I'll start, Gary. I think when we talk about, when people ask about can you do too much, they sort of think about things like if you do too much exercise, do you die earlier, and big ticket items. And I think there the answer we can say is pretty concrete, which is you can't exercise yourself to death. You can do as much as you like. Martin made the point importantly that are you any healthier if you run marathons than if you just stay pretty fit? And there's a concept of the asymptote of benefit or diminishing returns, where when you're super fit, the health benefits become less and less, but they're still there. You don't tend to run out. There are these specific examples like atrial fibrillation where they do increase in the super fit. I often say it's a bit like tennis elbow or something. You play tennis and it's good for you. You also do have the chance that you can, get a sore elbow. And does it stop you from playing tennis? It wouldn't stop me. And similarly, the atrial fibrillation, which is a true pain in the bum or a rhythm in your chest, whatever you want to call it, but it can be managed, and it doesn't occur with every athlete. And I don't think it's a big enough ticket item to be advising people to put a ceiling on their exercise. So the short answer to what you said is go for it. If you enjoy it, do it.
Okay. Although I think I've had some patients over the years that have been exercise addicts, and you just can't get them to turn it down, no matter how much AF or whatever other consequence they get. I'd like to come back to the issue of prescription, social prescribing, and Jacques, you talked about nature prescriptions. What is a typical nature prescription, and how would a general practitioner get into that business?
Thank you. It's a very good question. It's actually this part of the research I'm conducting is not only looking about whether social prescribing or nature prescribing work, but how we implement it. Is this a piece of paper our GP or specialist write down and to our patients that someone do? Or there's maybe some formula they can choose, say, oh, this is what you want to do. I recommend you have 30 minutes walk in your local park per day, and then during the weekend you can go into do community garden. So this part, there's no sure answer, but someone do write down, say, this is what I recommend you do. And also some of the GPs or health professionals even recommend or refer their patients to some social activity or nature groups, such as community gardens or art gallery groups. So people can be together and doing something they find interesting. So I think enable it to work, and why it's also need to come from a health professional is because our health professional really know our patients well. You don't want to recommend something which the patient's probably is not capable to do and which could lead to injury. And that is also, as Nico said, our GP, our health professional, could be really powerful. And also from the survey which we conducted, and it shows that people do want to have a nature prescription or social prescribing from our health professionals. So I hope that our health professionals today here could really use their power to enable and empower our people to do more social prescribing and nature prescribing, and to be in nature more often. Thank you.
Gary, can you add something to that?
Yeah, please.
Yeah. So just with the whole social prescribing situation, apart from it having benefits, like Prof. Feng's mentioning in terms of in nature and physical activity, we now know that social isolation in itself is an independent risk factor for so many, chronic medical conditions. But in particular, what we're talking about, that it does increase the risk of having a heart attack, a stroke, and premature death by 30%. And it increases our risk of depression and dementia by 50% as well. These are studies that were conducted in the US. Last year, we had the US Surgeon General releasing a report in May of last year. So again, I think we've got so many benefits of having the social interaction or social connectedness, having nature, and also having physical activity all combined in one, so that we really are helping our patients optimize their health.
Yeah, and I think the issue of social isolation and loneliness, which are two different things, might be worth another webinar in itself, because it really is a big issue. But I was going to ask you, as Jacques said, GPs know their patients, and it's also very important that GPs don't validate poor health activities. We know that if someone's grossly overweight, it's not mentioned on the first visit by the GP. They think it must be all right, and probably the same thing applies to physical activity. I think when we come down to nature prescribing, would it help for GPs to be informed better about what's available in their local community, what sort of facilities? There are all sorts of things that you just don't come across unless you look for.
Absolutely. And this is like Prof has just mentioned, that's something that we're working on, how to implement it nationally in primary care. But having knowing our local services through council or just our own community resources is really important for us GPs, so that we can actually say, hey, if you like going for walks in the park, these are the parks that are in your suburb, or, there's this dance group there, or the park run that's there every Saturday. So we really need to be familiar, I guess, with what is available in our locale, if you like. And if we are familiar with that and we have trust in those providers, then we can actually better inform our patients as well. So it is very important to firstly know our own resources locally so that we can share that with our patients.
Thank you. I'm going to come back to some clinical questions now, because there are a lot about what particular patient groups should or shouldn't exercise. People with atrial fibrillation, people with heart failure with preserved ejection fraction, people with SCAD, sudden cardiac artery dissection, post-COVID with or without myocarditis. What are your thoughts, and it's probably for Andre, Martin, Nicole, and Kulit, about advising physical activity for them? How do you go about selecting them? And you can pick any of those you like.
Andre, were you going to start?
Well, maybe I could start just by saying that, and I don't mean this to be a cop-out, but it is difficult to give generalised advice across all of those topics. But even if we were to choose one, I think it's highly individualised. I might just start with atrial fibrillation, for example, where it really comes down to a discussion with the person. I see that sometimes people are advised to slow down or stop or whatever, where in fact, atrial fibrillation is not a life-threatening condition, and if people feel all right, they can continue to exercise. There's no evidence yet, we're doing a study at the moment, there's no evidence yet that detraining has any impact on atrial fibrillation. I think that the post-COVID world is very interesting in terms of the variation of advice and guidelines. I think what people I suppose as a golden rule, question anyone who puts up a barrier to exercise, because in almost all settings, there's some way in which you can exercise. And so you should be able to find a doctor in whom you can have a relationship and discuss your personalised return or start to exercise.
That's great.
Martin or Nicole, do you want to jump in there?
Yeah, I might just jump in and say, there are some absolute and relative contraindications that we can't dismiss. So, regardless of the condition, there's some absolute and relative contraindications. But if someone is stable, the benefits of being physically active far outweigh the harms of not. So we should be encouraging all of our patients, if they're stable, if there are no absolute contraindications, we need to consider those relative contraindications. If you need specialist exercise advice, you should signpost, refer. So refer to an exercise specialist, a physio, an EP. Medical clearance in someone that's stable for low to moderate intensity is generally not needed. For a higher intensity activity, yes, absolutely, you need to have medical clearance. But for that lower to moderate intensity, you should be encouraging your patients to do that if they are stable and there are no absolute contraindications. And, there are patient populations, heart failure patient groups with low ejection fractions that are doing high intensity interval training, and the results are really positive. So I think we are quite conservative here in Australia. Of course, it requires a thorough assessment, and you need to consider all of those things. But if a patient is stable and there's none of those contraindications there, start slowly, progress gradually, make sure it's the right exercise prescription by an exercise specialist. General physical activity, any of us can do that. Any health professional can encourage general physical activity. But if you want a more specific plan, refer on to those exercise specialists.
If I may add to Nicole and Andre, Gary, is that okay? Still adding. I would like to highlight that the basis is medication. Although it's not a topic today, but in patients, don't change the medication, and go on guidelines to do that. Whether it is HFpEF, heart failure, whether it's myocarditis or post-COVID, whatever. The second issue is when we talk about physical activity, exercise, and when it comes to patients, we mostly think of endurance exercise, walking and brisk walking and so forth. But the concept in cardiac disease is strain the periphery and protect the heart. And so it is resistance training, for example, or sitting on the wall as the most easiest way to go is not. This can be done in any patient, and I would like to say any patient, because this heart failure patient can be severely or severely diseased older individual. Adapting isometric exercise or resistance exercise, and then on this basis, then integrate then also endurance exercise. And the most extreme example, as Gary, you mentioned, somebody asked about myocarditis, and we then say, oh no, no exercise in myocarditis for 3 or up to 6 months. This is endurance. If it comes to resistance exercise or sitting on walls and coordination and all this yoga, do it. So I think that and my third issue is when it comes to GPs, don't. Or I think what you shouldn't do is just refer. Referral is you lose patients. So you really have to be the one who takes on the lead. And as I would like to give you one example, what I do, and this is when I prescribe exercise, I say, okay, now let's sit on the wall, you next to me, and then we discuss your medication. So this is for mind change. And I think you as doctors, or we all as doctors, have to really, with easy measures, go along prescribing exercise, and our patients have to see that we really are involved in exercise and seeing this as a clear strategy in our patients and for them. So medication on one side, and then they get a prescription exercise to the other. And please hand this out. Write down 5 minutes a day of whatever brisk walking from your house to within the neighborhood or to the next tree. So whatever. So write it down, and this is for the fridge. So put it on the fridge, and then think of me. This is what I tell my patients.
Right, very practical. Sorry. Look, we've got so many good questions and lots of good suggestions and comments, and I'm really sorry we're not going to be able to deal with them all. I've got one more because I think it's a pretty common one, probably for you, Andre, and that is we've only got 30 seconds. What's your approach to the athlete who comes along with an abnormal ECG?
To ask them about their symptoms and sometimes to do further tests. It's a little bit of a specialised field. I mean, there's a lot of changes on the ECG that are actually normal in an athlete, but when we really see something that's abnormal, particularly things like T-wave inversion, then we need to do further tests and ask about their symptoms and also ask about their family, because a lot of these are inherited conditions. So it's a very good question. It's an important gateway into our world, the ECG.
And I think, so from a general practice perspective, if there's any question at all, refer, because it is a specialised field, and as you say, there are subtleties around the ECG pattern that that people that understand this area can work with.
And also, I suppose, just very quickly, because related to the questions before, is it's a rapidly evolving field. We would have said 5 years ago, hypertrophic cardiomyopathy, stop exercising. Now, a lot of us are allowing, encouraging even people to exercise. So a lot of the contraindications of the past are now indications. So it's worth staying in contact with someone who's really passionate about this field.
Yeah. Okay, I think we better finish now, even though I'd like to go on for another half hour. This has been a terrific discussion, and I'm very grateful to all our participants and the different perspectives they brought to this important issue. And as I said, I'm just so sorry there are all sorts of other important issues we could have discussed if we had another hour. Just to wrap up some of the Heart Foundation activities and resources which might be helping as far as these questions are concerned. The Heart Foundation Walking Program has got many thousands of groups around, people around the country working in many hundreds of groups on regular walking, and that's very effective and very accessible and very cheap. Next slide, please. We have another slide coming. There's the Heart Health Check Toolkit. All of this is online at heartfoundation.org.au. And we have, next slide, the My Heart, My Life digital program, where people can get digital support for people living with coronary heart disease and those caring for them. And although Nicole didn't go into it too much, there's a big problem with access to cardiac rehabilitation programs. And this is an example of the emerging trend for people being able to help themselves as well with the support of their general practitioners and cardiologists. And next slide, please. The new acute coronary syndrome guideline, which has a big element of post-acute care in it, will be coming out soon and early in 2025. And if you're in the Heart Health Network, you'll get early access to that as well. And I think you'll find that that's got contemporary evidence-based best practice. So thank you all for joining us. It's been a fantastic session. We've had a terrific panel, and I wish you all a very good day, night, evening, wherever you are.